Today we'll be covering Chapter 38, Pediatrics. We'll be using the Prehospital Emergency Care 11th edition, and this is brought to you by Southern Star Health Education. Many MS providers agree with the stressful nature of pediatric emergencies. Trauma is the leading cause of fatal injuries in children under the age of 14. Of medical problems, respiratory problems are the most serious in children. An assessment of the pediatric patient varies somewhat different than that one from the adult. Caregivers may be upset, cry, blame themselves, or be angry. Listen carefully and remain non-judgmental. Let caregivers verbalize their emotions and be supportive and display competence and confidence. Dealing with a child. Developmental characteristics. Each age group has specific emotional and physical characteristics that affect assessment and treatment. Pain is difficult to assess in most age groups. And ask caregivers what typical reactions are for the pediatric patient when you're dealing with them. Neonates usually are from birth to 1 month. Infants 1 month to 1 year. Toddlers 1 to 2 years of age, and preschoolers are 3 to 5 years of age. School age pre-adolescent children are 6 to 12, and adolescent children are 12 to 18. These are the anatomical and physiological differences in children. They have less blood in their system. Children also have a lower blood pressure. They have a faster heart rate. And when it comes to any kind of loss of blood or temperature changes, their skin reacts a lot different than with adults. Children also have head larger than regular, for the body size. The temperature control mechanism is immature at this point. Children also have a smaller airway. Children have a faster respiratory rate. And children, in cases of emergencies, can dehydrate a lot faster than adults. This table indicates the estimated pediatric heart rate, respiratory rate, systolic blood pressure, and diastolic blood pressure based on age. So neonates, the heart rate is usually 100 to 205. Respiratory rate is 40 to 60. Systolic blood pressure is 67 to 84. Diastolic blood pressure would be 35 to 53 millimeters of mercury, and systolic hypotension would be less than 60. Infant, 100 to 180 heart rate. Respiratory rate is 30 to 53. Systolic blood pressure is 72 to 104, and diastolic blood pressure is 37 to 56, and systolic hypotension occurs at less than 70. Toddlers, the heart rate is 98 to 140. Respiratory rate is 22 to 37. Systolic blood pressure is 86 to 106, and diastolic blood pressure would be 42 to 63. And systolic hypotension occurs in less than 70. Age in years times 2 is a calculation that we use. Preschool, 80 to 120, it would be the heart rate. Respiratory rate is 20 to 28. Systolic blood pressure, 89 to 112. Diastolic blood pressure, 46 to 72. And it's the same with the systolic hypotension, which would be less than 70 plus the age in years times 2. School age children have a heart rate of 75 to 118. Respiratory rate is 18 to 25. Systolic blood pressure is 97 to 120. Diastolic is 57 to 80. And the same thing, less than 70 plus the age in years times 2. Adolescents, the heart rate is 60 to 100. Respiratory rate is 12 to 20. Systolic blood pressure would be 110 over 131, 110 to 131. And diastolic blood pressure is 64 to 83. And any significant hypotension will be at less than 90 millimeters per mercury. Anatomical and physiological differences. The airway is different. Head's larger. chest and lungs are different, and respiratory system is also different. Cardiovascular system, abdomen, extremities, metabolic rate, and skin and body surface areas also. Assessment-based approach to pediatric emergencies. Do a scene size-up, look for clues to the nature of the problem, assess the need for additional resources, and determine your own personal safety. Assessment, form a general impression using the pediatric assessment triangle, also known as PAT. Assess the level of consciousness, assess the airway, assess the breathing, assess circulation, and determine the priority of the patient. Primary assessment from the doorway. Pediatric assessment triangle, look for appearance, work of breathing, and circulation to skin. When we use PALS, pediatric advanced life support, look for consciousness, breathing, and color. Form a general impression using the pediatric assessment triangle. Look for appearance. When we look for appearance, we're looking for tone, interactivity, and irritability, consolability, look or gaze, and speech or cry. Work of breathing, abnormal sounds, abnormal posture, positioning, retractions, nasal flaring, and head bobbing. To the skin for pallor, mottling, cyanosis, and petechia. Primary assessment. Form a general impression using the pediatric assessment triangle, also known as PAT. Differentiate from a well versus a very sick child in your general impression. Conditions presenting with an abnormal PAT findings. Consciousness, breathing, color. If breathing is adequate, proceed to primary assessment. If the patient is unresponsive and breathing is absent or gasping, begin positive pressure ventilations at 12 to 20 respirations per minute and assess the pulse. If there's no pulse, begin chest compressions. If there's a pulse, but signs of poor perfusion are present, and the heart rate lies less than 60 beats per minute, begin chest compressions. If the pulse is greater than 60 beats per minute, proceed with primary assessment. Use the AVPU approach. Check for alertness, verbal response, painful response, or unresponsive. In primary assessment, this is the way you basically do the airway assessment. Go ahead and lift up the chin to open up the airway and check for breathing. Rapid breathing, normal breathing rate is about 20 to 25 in an infant and 15 to 30 in a child. Check for signs of hypoxia and respiratory distress and the causes of rapid breathing. Check for noisy breathing, coughing, gagging, gasping, crackles, wheezing, stridor, or diminished breathing itself. Pulse. Capillary refill is reliable in children. Remember, anything less than 2 seconds is considered normal. Also assess blood pressure, urine output, and mental status to check for hypoperfusion. Pulse rate and strength of peripheral versus central, warmth and color of hands and feet, urinary output, and mental status. Assess the strength of peripheral pulse in an infant. Check for brachial pulse. Femoral pulse in an infant. Locate the pulse by identifying the midpoint of an imaginary line extending from the anterior superior iliac spine to the symphysis pubis. Then moving your fingertips about 1 to 2 fingers breadth inferiorly. If a child, check for radial pulse. Compare the strength of central pulse to previously determined strengths of peripheral pulses to see if there's any weakness to the pulse. To check for capillary refill, in this case, a blanching test, go ahead and press hard on the skin itself and release, and note how long it actually takes to the color to go back to normal. Consider scene size up, PAD or PALS, and primary assessment information. Priority patients, respiratory distress, respiratory failure, respiratory arrest, and poor perfusion. Trauma, perform an assessment first, then the history and baseline vital signs. For a responsive patient with a medical problem, a focused assessment may be performed. For younger patients, use a head to toe, the opposite, the toe to head approach. Or examining an infant or a child, if possible, have only one EMT deal with the infant. This reduces the fear and anxiety that the patient might actually have. Get down to the infant's eye level, if not below. Towering usually causes fear and anxiety. With children under the school age, start the assessment with your hand and save the stethoscope, blood pressure cuffs, and scissors until you have developed some trust with the child. Keep the most painful parts of the examination to the very end. Speak in calm, quiet, and maintain contact as much as possible. Even infants will respond to a calm voice, and an apparently unresponsive child may actually hear much more of what you actually say. Never become impatient or lose your temper. Avoid questions that require yes or no. Involve the caregiver or a familiar person to basically help you with the assessment. Be honest. For instance, you might actually say, it will hurt when I touch you here. Ask children for their help and assure that they are doing a good job. Be gentle. Use all appropriate measures to reduce the amount of pain the patient might actually. Special considerations in the physical exam. The pediatric Glasgow Coma Scale, assessing lung sounds, and pulse oximetry. Evaluating blood pressure in a pediatric patient. In a neonate, systolic blood pressure less than 60 millimeters per mercury is considered hypotensive. In an infant, systolic blood pressure less than 70 millimeters per mercury is considered hypotensive. In a child 1 to 10 years of age, upper limit of normal systolic should be 90 plus 2 times the age of the child. And so on. Child older than 10 years of age, systolic blood pressure less than 90 is considered hypotensive. Special considerations in assessing vital signs. Respirations, check for pulse, check for skin, pupils, and blood pressure. Secondary assessment, consider for taking a history. Watch a child's interaction with a caregiver. Where there are no life threats, take time to establish trust and use calm voice, and include the child in the actual conversation. Avoid rapid fire yes or no questions. Avoid words that increase anxiety. Keep the child with the parent. Examine small children toe to head, and place yourself at the child's eye level. Do not explain things too far in advance. Let the child handle equipment before you actually put the equipment on the child. Monitor mental status, airway, breathing, and circulation. Remember that compensatory mechanisms fall very rapidly without warning in children. Assess and record vital signs and check for interventions. Respiratory problems in pediatric patients. The leading cause of cardiac arrest in pediatric patients is respiratory failure. Failure to establish and maintain the airway and ventilations will defeat any other treatment and lead to failure. Compensatory mechanism functions until total exhaustion occurs, causing the respiratory and cardiac arrest. In early respiratory distress, There's adequate depth and rate of respirations. Work of breathing is increased. The patient can progress to respiratory failure and respiratory arrest, and you have to provide oxygen and transport. Here's a diagram of findings for a child in respiratory distress. And these are the ones that we just went over just a few seconds ago. Signs of early respiratory distress: flared nostrils, neck muscles retractions, supraclavicular retractions, intercostal retractions, and you have seesaw breathing. In other words, while the chest is going down, the stomach is going up. You might actually have stridor, grunting, suprasternal retractions, audible wheezing, and subcostal retractions. If signs of early respiratory distress are present, provide O2, oxygen, and prompt for transport to the hospital itself. Decompensated failure, respiratory failure. The patient cannot compensate and is unable to maintain adequate breathing. Either the respiratory rate or the tidal volume is inadequate and the patient requires immediate interventions. And these are the findings that you're going to get when you have a child in decompensated respiratory failure. In addition to signs of respiratory distress, patients in respiratory failure may actually have respiratory rate greater than 60, cyanosis, decreased muscle tone, and severe use of accessory muscles. Decompensated respiratory failure. In addition to signs of respiratory distress, the patient in respiratory failure may actually have respirations greater than 60 per minute, cyanosis, poor peripheral perfusion, altered mental status, grunting, and head bobbing. In respiratory arrest, the respiratory rate is less than 10. Irregular or gasping respirations, limp muscle tone, unresponsiveness, slower than normal or absent heart rate, weak or absent peripheral pulses, and hypotension. And here's a diagram of findings of child in imminent respiratory arrest. In airway obstruction, you have partial airway obstruction. If the airflow is adequate, allow the patient to assume a comfortable upright position, administer O2, encourage the patient to cough, do not agitate the patient, and transport immediately. When you have complete airway obstruction, you can't hear any crying or talking, ineffective or absent cough, altered mental status, cyanosis probable, and requires the use of procedures for relieving the airway obstruction. And usually those are the ones that are associated with CPR. Emergency medical care: establish and maintain the patient's airway. If no cervical spine injury is suspected, use head tilt chin lift maneuver. If a spine injury is suspected, use a jaw thrust maneuver. And this is a diagram or a picture of a head tilt chin lift maneuver in an infant. And remember, you have to avoid overextension. Head tilt chin lift maneuver on a child. Jaw thrust maneuver in an infant. Jaw thrust maneuver on a child. Emergency medical care: respiratory emergencies, emergency care for obstructed airways, suction, secretions, vomitus, or blood. Limit your suctioning to 3 to 5 seconds and use appropriate sized equipment. Assisted ventilations: if positive pressure ventilations is needed, insert an oropharyngeal airway if the patient does not have a gag reflex. In general, avoid the use of nasopharyngeal airways in pediatric patients. These are different sizes of an oropharyngeal airway. Remember, pediatric patients, children or adolescents. Remember to measure. Inserting the oropharyngeal airway using a tongue depressor for insertion in a pediatric patient. Here's a picture on how the oropharyngeal airway actually correctly sits to displace the tongue so airway can actually be open. Emergency medical care and respiratory emergencies. Assist ventilations as needed. Initiate positive pressure ventilation for respiratory failure or respiratory arrest. Ventilate 20 to 25 times per minute. Attach supplemental oxygen and use an appropriate size BVM or bag valve mask. This picture is the correct placement of a properly sized mask is necessary to ensure a good mask seal. Correct placement of the mask itself, remember, goes from the bridge of the nose to the bottom of below the lip itself. Remember, you have to do a seat clamp also. Here it is a picture on how it's actually supposed to sit. Remember that there's a 50mm port that will attach to any respiratory device that's out there. One-handed technique, place the middle ring, middle finger of your non-dominant hand along the jaw in the form of an E or a 3. Place the thumb and index finger on the mask in a C shape, thumb over the bridge of the nose and index finger over the anterior jaw. For a two-handed technique, position yourself behind the patient or the patient's head and apply an E or C or 3C shape. Position as described for the one-handed technique, but with two hands on opposite sides of the mask itself. Oxygen therapy. If the patient is breathing adequately, administer oxygen to maintain an SpO2 greater than or equal to 94%. If the patient cannot tolerate a cannula or mask, try the blow-by method. Make sure that the mask itself is appropriate for the child. To administer oxygen blow-by method using an oxygen tubing or a paper cup, it's appropriate for an infant or for a child who will not tolerate a mask itself. Position the patient in respiratory distress, unresponsive patients, patients in need of ventilation, and patients requiring spine motion restrictions. Transport the patient if they have respiratory distress complaints, if they have respiratory distress findings, and transport to Children's Hospital if possible. You have suspected foreign body airway obstruction if there is high resistance of airflow with positive pressure ventilation. Attempt to reposition the airway first. If no success, assume the airway is obstructed. Infant or child with a mild foreign body airway obstruction if the foreign body and not airway infection, then suspect that then take actions to clear the airway itself from. Infant or child with a mild foreign airway obstruction, do not intervene. Allow the patient to continue coughing. Provide supplemental O2 and monitor for worsening conditions. Infant with severe foreign body airway obstruction, if the patient is still responsive, initiate steps to remove the obstruction. Position an infant to deliver back slaps. Use your finger sweep only when the foreign body is visible. Emergency medical care. Unresponsive infants with foreign body airway obstruction. If the patient is unresponsive, initiate steps to remove the obstruction. Child with severe foreign body airway obstruction. If the child patient is responsive, initiate steps to remove the obstruction itself. Abdominal thrust on a choking child but responsive child. Unresponsive child with foreign body airway obstruction. If the patient is unresponsive, initiate steps to actually remove the obstruction. Chest compressions on a child who is unresponsive. For an older child, place your one hand on top of the other. Croup. This is specific pediatric respiratory and cardiopulmonary conditions. Croup is an infection of an upper airway common between 6 months to 4 years, causes swelling beneath the glottis, and presents with a seal bark cough, severe attack can lead to respiratory distress. Now here's a pro for you. To diagnose croup, remember it's an infection, so there's going to be fever, and it usually happens from 6 months to 4 years. And they're going to have that seal bark cough. Here's the difference between epiglottitis and croup. On croup, you're going to have swollen larynx. And in epiglottitis, as the word states, epiglottitis, you're going to have a swollen epiglottis. Administer O2 humidified if possible to maintain an SpO2 greater than equal to 94%. Keep the patient in a controllable position and transport without agitating the patient. Epiglottitis is a bacterial infection that causes swelling of the epiglottis, usually between the ages of 2 to 7. If untreated, it has a 50% mortality rate and rapid onset with high temperature. So another pro for epiglottitis would be to use, it usually occurs from the ages of 2 to 7 years of age, and there's a high fever. Specific signs and symptoms: pain on swallowing, high fever, toxic ill appearance, drooling of the mouth, changes in voice quality, pain in speaking, chin and neck thrust outward, and you have a respiratory stridor. So this is a stridor that you're going to hear on the neck area while they're breathing in. Emergency care: do not place anything in the child's mouth. Place patient in comfortable position, oxygen and non-rebreather mask or blow-by method. Consider ALS backup and rapidly transport the patient to the hospital. Asthma: it's an inflammatory process characterized by increased mucus production, swelling of the airways, and smooth muscle contractions. Now, what happens when you have smooth muscle contractions and swelling? You're going to have swelling of the inner lumen of the bronchiole itself, or the bronchial trees. You have swelling that usually constricts the mucus-producing cells, causing it to produce mucus. Signs and symptoms: shortness of breath, chest tightness, squeezing, and non-productive tight cough. Questions to ask regarding medical history: how long has the child been wheezing? Have they had a recent cold or other infection? Have they had any medications for this attack? And if they did, what was it when they took it, and how much did they take? Do they have any known allergies to foods, to drugs, foods, pollens, or other inhalants? Remember, in some of the cases, you're going to have temperature causing them to actually, very cold temperature can actually cause you to have an asthmatic attack. Pay attention to the position of the patient, if they're in the tripod position, mental status, vital signs, skin color and conditions, and respirations. Maintain oxygen to keep pulse greater than 94%. Initiate positive pressure ventilation. If patient's condition deteriorates, assist with prescribed inhaler. If present, consider ALS backup and transport to the emergency. The mucosal layer in bronchitis. The mucosal layer of the bronchioles is inflamed by actually viral infections, usually is the RSV virus. This produces wheezing and other signs of symptoms of asthma. There's usually a low-grade fever, often more predominant in patients less than 2 years of age. And you have inflammation of the airways. The inner lumen of the airways can actually cause mucus production by squeezing the mucus-producing cells, which will now release mucus into the airways. Maintain an oxygen saturation of 94% and above. Initiate positive pressure ventilation. Place patient in position of comfort. Monitor vitals and mental status en route, and consider ALS backup. Pathophysiology of pneumonia. You have mucus inside the bronchioles, which leads to a reduced airflow, and mucus in the alveoli causes poor gas exchange. So now you have not only having the cell wall as a barrier for gas exchange of CO2 and O2, but now you have fluid in there, which actually causes you to actually have very little oxygen and carbon dioxide exchange. Pneumonia is caused by an infection in the lungs, can actually obstruct the airways and lead to respiratory compromise. Signs include shortness of breath, chest tightness, diminished breath sounds, and cough. Pneumonia assessment, look at the position of the patient, mental status, vital signs, skin color, condition, and respirations. Maintain an oxygen level above 94%. Initiate positive pressure ventilation if needed. Place patient in a comfortable position. Transport the patient and consider ALS. Specific pediatric respiratory and cardiopulmonary conditions. Congenital heart disease can be due to abnormal valves, vessels, or chambers. Results in more deaths during the first year of life than actually other birth defects. And key is to recognize an abnormality may actually exist, rapidly transport the patient to the hospital. Congenital heart disease can actually may be present with inadequate pulmonary blood flow with cyanosis and hypoxia, excessive pulmonary blood with congenital heart failure, hypoperfusion, and shock. You also have respiratory distress with or without cyanosis or shock. Emergency medical care for these conditions: maintain oxygen to keep pulse ox greater than 94%. Initiate positive pressure ventilation if patient's condition deteriorates. Support the cardiovascular system as necessary. Transport immediately and consider ALS backup to intercept you. Shock. Causes include hypovolemic, obstructive, distributive, and cardiogenic. Less common causes of shock are allergic reactions, poisonings, and cardiac events. Common findings include diarrhea, dehydration, trauma, vomiting, blood loss, infection, and abnormal injuries. Picture of the signs of shock. In a child, you have rapid respiratory rate, absent tears when crying, impaired mental status or unresponsiveness, weak or absent peripheral pulses, delayed capillary refill, pale, cool, clammy skin, and decreased urination. 38-7, pulse and capillary refill as indicators of compensated and decompensated shock. Emergency medical care. Maintain an open airway and use oxygen to maintain SpO2 at 94% or higher. Use positive pressure ventilation if breathing is inadequate. Control bleeding if present. Keep the patient supine and warm and transport rapidly. Consider ALS intercept. Establish and maintain an open airway, extending the head only enough to allow an open airway to avoid hyperextension. Suction secretions. Provide positive pressure ventilation with a supplemental oxygen connected to a ventilation device at a rate of 12 to 20. If breathing is adequate, administer oxygen via non-rebreather mask at 15 liters per minute. Consider blow-by oxygen in infants and very young children. If shock is due to blood loss, control any external bleeding with direct pressure. If internal bleeding is suspected, transport immediately and expeditiously. The patient warm. If hypothermia is suspected, wrap the patient in warm blankets and place the ambulance heater on high. Cover the infant and child's head. Consider calling advanced life support. Expedite transport and perform reassessment every 5 minutes. Cardiac arrest. Almost all cardiac arrest in children results from airway obstruction or respiratory distress leading to respiratory arrest. Shock is also a cause of cardiac arrest. Aggressively manage both respiratory problems and shock before they progress to cardiac arrest. Signs of cardiac arrest include unresponsiveness, gasping, or no respiratory sounds, no audible heart sounds, chest is not moving, pallor, cyanosis, and absent pulse. Emergency medical care, positive pressure ventilation with supplemental oxygen, CPR and AED application, early ALS backup or intercept, and rapid transport. Can actually be applied to a child or an infant. This is the way you set it up. Seizures. Abnormal electrical discharge that occurs in the brain. Seizures are a brain dysfunction with muscular manifestations. The causes for seizures could be fever, epileptic, drug overdose, brain tumors or brain injury, electrolyte abnormalities, hypoglycemia, meningitis, and hypoxia. Assessment: check for muscular rigidity or twitching, dilated pupils, irregular breathing, incontinence, cyanosis, and excessive salivation. History and findings: patient might actually have a history of prior seizures. If so, is this a normal pattern? Has a child taken any prescribed medications, and what was the duration of unconsciousness? And describe the seizure activity. Maintain an open airway when dealing with emergency medical care, and make sure that you keep that SpO2 greater than 94%. Provide positive pressure ventilation if breathing is inadequate. Position the patient on their side. Be prepared to suction and transport. Emergency care protocol, pediatric seizures. Establish and maintain an open airway, extending the head only enough to allow an open airway and avoid hyperextension. Protect the infant or child from injuring himself. Place him on his left side. Suction secretions. Provide positive pressure ventilation with supplemental oxygen at least at a rate of 12 to 20. If breathing is adequate, administer oxygen to maintain SpO2 greater than 94%. Consider blow-by oxygen in infants and young children. Check for blood glucose levels if the protocol permits. Expedite transport in any of the following situations: epileptic seizures lasting greater than 5 minutes, 2 or more epileptic seizures without a period of consciousness or between them, febrile seizures lasting more than 15 minutes, seizure from any other cause, hypoxia, head injury. Consider calling advanced life support. Expedite transport and perform reassessment every 5 minutes. Altered mental status in children. The change to mental status could be mild to significant. There are many underlying causes of altered mental status in a pediatric patient. The goals are to manage threats to the airway, breathing, and oxygenation and circulation. Assessment considerations: use modified ABPU or GCS scale. Medical care: maintain an open airway, use oxygen to keep SpO2 levels at greater than 94%. Apply positive pressure ventilation if breathing is inadequate. Position the patient on their side. Prepare to suction and transport, and consider ALS intercept. Establish and maintain an open airway, extending the head only enough to allow an open airway and avoid hyperextension. Suction secretions. Provide positive pressure ventilation with supplemental oxygen at a rate of 12 to 20 ventilations per minute. If breathing is adequate, administer oxygen and maintain an SpO2 greater than 94%. Consider blow-by oxygen in infants and very young children. Check blood glucose levels if your protocols. The signs of symptoms of hypoglycemia are present, and the child is known as a known diabetic on medications for the condition. Consider oral glucose if the child is able to swallow and medical direction approves it. Consider calling advanced life support, expedite transport, and perform a reassessment every. Drowning can actually occur in a very small amount of water. Most drownings are dry drownings. Assessment considerations: be aware of associated trauma and hypothermia, possibly of secondary drowning syndrome. Emergency medical care: consider spinal injury, maintain an open airway, and use oxygen to keep SpO2 greater than 94%. Use positive pressure ventilation if breathing is inadequate. Place the patient on their side. If possible, provide CPR and use the AED if needed. Transport with ALS backup or intercept. The infant or child from the water. If diving was involved in children and adolescents, consider spine motion restriction. Establish and maintain an open airway, extending the head only enough to allow an open airway and avoid hyperextension. Suction secretions: provide positive pressure ventilation with supplemental O2 connected to a ventilator device at a rate of 12 to 20. Perform chest compressions if no pulse is present. Apply the AED. Contact medical direction otherwise for orders. If hypothermia is suspected, deliver only one defibrillation. If breathing is adequate, administer oxygen and maintain SpO2 levels of 94% or greater. If hypothermia is suspected, remove the clothing, wrap the patient in a warm blanket, and place the ambulance seat on high to cover the infant's or the child's head. Consider calling advanced life support, expedite transport, and perform reassessment every 5 minutes. For fevers of 104 to 105 Fahrenheit are concerning. Causes include infection and heat exposure, seizures, and dehydration may actually occur. Assessment considerations: rise of temperature more important than actual temperature. Changes may occur to pulse amplitude. Fontanelles may be sunken if the infant, and urinary frequency may actually be diminished. Emergency medical care: maintain an SpO2 greater than 94%. Remove excess layers of clothing. Consider patient as needed in a controlled fashion and be alert for seizures. Establish and maintain an open airway, extending the head only enough to actually allow an open airway to avoid hyperextension. Suction secretions: provide positive pressure ventilation with supplemental oxygen via a reservoir at 12 to 20 ventilations per minute. If breathing is adequate, administer oxygen and maintain the SpO2 levels at least 90%. Febrile seizures greater than 15 minutes are a dire emergency and require expeditious transport and consideration for advanced life support. Consider calling advanced life support, transport, and perform reassessment every 5 minutes. Meningitis. Meningitis is an infection of the lining of the brain and spinal cord. Fever in infants younger than 3 months is suspected as meningitis and actually may be rapidly fatal. Meningitis causes a meningeal tissue to swell inside the skull and around the spinal cord, causing an increase in pressure inside the skull and compression of the brain itself. Assessment considerations: recent ear or upper respiratory infection, high fever, lethargy, nausea, vomiting. Fontanelle may actually bulge in infants, pain with movement, and possible skin rash. Wear a mask, gloves, and possibly a gown. Keep pulse ox at a greater than 94%. Ventilate the patient if needed and transport to the hospital. Gastrointestinal disorders. Assessment considerations: conditions include gastroenteritis, which can lead to dehydration and appendicitis. Emergency medical care: maintain an SpO2 greater than 94%. Place the patient in a position of comfort and anticipate vomiting and transport. Poisoning. Assessment considerations most common to children younger than 4 years of age. A thorough secondary assessment is critically important to find the cause, gather as much information as possible about the type of overdose prior to transport. Emergency medical care, contact medical direction or the Poison Control Center. If activated charcoal is ordered, the dose is 1 gram per kilogram. Maintain an open airway and adequate ventilations and oxygenation and transport with frequent reassessments of mental status, airway, and breathing. Head only enough to allow an open airway. Avoid hyperextension, suction secretions. Provide positive pressure ventilation with supplemental oxygen at a rate of 12 to 20 ventilations per minute if breathing is inadequate. If breathing is adequate, administer oxygen to maintain an SpO2 level of 94% or higher. Consider a blow-by oxygen in infants and very young children. Treat for specific poisoning suggestions. If you are instructed to administer activated charcoal and the patient is alert and able to swallow, give 1 gram per kilogram. Activated charcoal is contraindicated for the following reasons: altered mental status, ingestions of acids or alkalis, and patient who is unable to actually swallow. You have inhalations, remove the patient from toxic environment, maximize oxygenation to non-rebreather mask at 15 liters per minute if breathing adequately, or positive pressure ventilation if breathing inadequately. You have absorption, flush with water for 20 minutes. At the scene, if eyes are involved, continue flushing. Monitor airway and breathing if allergic reaction, and with order from medical direction to consider administration of epinephrine at 15 milligrams or 0.15 milligrams if the child weighs less than 66 pounds. If the child weighs more than 66 pounds, you can go ahead and give 0.3 milligrams. Those should be used. Apply constricting band proximal to the site of the bite or injection. Consider calling advanced life support. Expedite transport and perform reassessment every 5 minutes. Brief resolved unexplained events. Assessment considerations. An episode that is frightening to the observer is infants younger than 1 year of age. This is usually characterized by some combination of apnea, color change, marked change in muscle tone, choking, or gagging. Event usually is transient. Emergency medical care, maintain an open airway and adequate breathing and oxygenation. Apply positive pressure ventilations for inadequate breathing and transport with ALS intercept. SIDS, also known as sudden infant death syndrome. Sudden and unexpected death of a child in which an autopsy fails to identify the cause of death. Usually the peak incidence in these cases is 2 to 4 months. Exact cause is usually unknown, cannot be diagnosed in the field. Physical appearance of the infant, position of the infant in the crib, physical appearance of the crib itself, presence of objects in the crib, and unusual or dangerous items in the room. Attempt resuscitation unless rigor mortis is actually present. Encourage caregivers to talk. Do not provide false reassurances. Transport with ALS backups or intercept, and use caution in communications. Aiding family members in SIDS. Reactions vary, but shock and disbelief are very common. Making decisions may actually be difficult for the parents. Be supportive and aware of your own emotions. Presence of children during pediatric resuscitation. Allow parents to be present during resuscitation attempts. Infants who survive also more accepting in procedures when parents are present. Pediatric trauma. Thousands of children die from unintentional injury, and more are permanently disabled. Leading cause of death from ages 1 to 14. 50% of deaths from trauma occur within the first hour after the injury, and maybe many of the deaths and injuries are preventable. Mechanisms of injury, common modes of injury, understate motor vehicle collisions, pedestrian versus vehicle, cyclist versus vehicle, water accident, blunt trauma, sports injuries, or child abuse. Assessment considerations: check the head, chest, abdomen, extremities, and burns. Head injury in common children because relatively large size of the child's head. It's scarier than it looks, but here's another one. Maintain an open airway and provide high concentrations of oxygen. Provide post-pressure ventilation if breathing is inadequate. Provide spine motion restriction is needed, and transport rapidly to a trauma center. Infants and child car seats in trauma can actually protect a properly secured child from injury, particularly with frontal and rear end collisions. More than half of the children are improperly secured or not secured at all. Removing the infant or child from a car seat, if the seat was involved in a moderate to severe crash, do not use it to transport the patient. If the crash was minor, the seat may actually be used if certain criteria are met. Infants and child car seats in trauma. Removing the infant child from the car seat, the vehicle was able to be driven away from the car site. The vehicle door nearest the safety seat was actually undamaged. There were more injuries to the occupants, or no airbags deployment or damage to the seat itself. Removing the infant from the car seat. If the child must be removed from the car seat, it must be done in a coordinated manner, maintaining an inline stabilization of the C-spine or the spinal. Safe transport the children in ground ambulances. Guidelines established National Highways Traffic Safety Administration. The National Highway Traffic Safety Administration of 2012 recommendations for safe administrations are divided into 5 different situations. Ideal recommendations are provided if they are not achievable. Other practical recommendations actually are provided. Transport of children in ground ambulances. Uninjured or not ill child at the scene, or an injured or ill patient. Injured or ill child who does not require intensive monitoring, and child who requires continuous intensive medical monitoring or intervention. Child who is actually conditioned requires spinal immobilization or lying flat. Child requiring transport is part of multiple patient transport. At times, the EMT may actually be able to improvise the restraint of a child with equipment intended for an adult. Here's a picture of a patient using the 3 straps across the patient of the chest wall and above the knees themselves. Place straps across the head and chin and securely affix the patient's head to the pediatric sleeve. Fully secured and backboard device on an infant. Injury prevention. Preventable childhood injuries account for 44% of deaths between the ages of 1 to 19 years of age. Injury prevention must be paramount concern to the EMS provider. Physical abuse takes place when improper or excessive actions is taken to injure or cause harm. Sexual abuse indicates the involvement of child in sexual activities for the gratification of an older or more powerful person. Neglect is the provision of inadequate attention or respect to someone who has a claim of that attention. Emotional abuse takes place when a person shames, ridicules, embarrasses, or insults another to damage the child's victim's self-esteem. Usually the adult who abuses a child often behaves in an evasive manner and may show outright hostility towards the child. An abused child usually shows fear and reluctance when asked to describe how the injury occurred. General indications of abuse or neglect: multiple abrasions, lacerations, incisions, bruises, or broken bones, multiple injuries or bruises in various stages of healing, injuries on multiple planes of the body, unusual wounds and patterns of injuries, and a fearful child. Injuries to non-bumper areas such as the genitals, abdomen, back, buttocks, ears, and neck, and injuries to the brain, spinal cord that occur when the infant or child is violently shaken. Injuries that do not match the mechanism of injury that is described, lack of adult supervision, and untreated chronic illnesses. Malnourishment and unsafe living environment may be causes of this. Delay of reporting injuries, implausible explanations based on the child's developmental level. Heat radiator burns to child buttocks. It's a picture of injuries from a switch to the thigh of a school-aged child. You have loop marks as school-aged children from being whipped with an electric cord. Medical care guidelines for child abuse involve law enforcement if the scene is dangerous or you cannot gain access. Do not ask the child what happened while they are in the crisis environment. Perform a head-to-toe exam. Make observations as if the scene is a crime scene itself. Child to the hospital. Do not question the caregivers about the abuse and make accusations. Do not allow the child to be alone with a suspected abuser, and the EMTs are mandatory reporters for abuse. In other words, you have to report this. Document objectively, record details, keep information confidential. Emergency medical services for children is designed to ensure that all children have access to appropriate emergency care. Established in 1984, it has provided grant funding in all states. Family Centers cares advocates open communications with family members throughout the assessment and management of the child. EMS providers must be able to anticipate the physiological and emotional needs for the child itself. For infants and children can actually be very stressful because the lack of experience in treating them, fear of failure, and or identifying patients with your own children. Yourself, to reduce stress, realize that much of what you know about adults applies to children. Usually this occurs with variations and techniques. Practice the skills and focus on the tasks at hand. Lesson summary. Each age group has a specific emotional and physical characteristics that affect assessment and care. Use pediatric assessment triangle, also known as PALS, initial impression to form a general impression of whether the child is sick or well. Respiratory problems are common cause of medical emergencies in pediatric patients. If it is critical to recognize signs of respiratory distress and respiratory failure and to intervene immediately. SIDS is the sudden, unexpected death of a child in which an autopsy fails to identify the cause of death. Pediatric anatomy causes some differences in patterns of traumatic injury. Certain injury patterns and behaviors about a child or caregiver should alert you to a possibility of abuse or neglect.